Ladies and gentlemen, welcome to today's webinar. My name is Andrew Keneally, WCRI's Communications Director. We're so glad you could join us today for the webinar on the timing of physical therapy for low back pain. Does it matter in workers' compensation? Before we begin, I'd like to tell you a little bit about WCRI for those who might not be familiar with us. We're an independent, not-for-profit research organization providing high-quality, objective information about public policy issues involving workers' compensation systems. We serve as a resource for public officials and stakeholders, but we do not make recommendations or take positions. Studies are peer-reviewed with a focus on benefit delivery, and we enjoy diverse membership support, including government agencies, employers, insurers, labor unions, service providers, and others. And it is at this time that we would like to thank our members for their support of the Institute. Without your support, we wouldn't be able to provide the research that we do in webinars like this. For those who aren't members of WCRI, we hope you'll consider it. And we have more information on our website about the many benefits of being a member of WCRI. About today's webinar, the presentation is 60 minutes long. That's 40 minutes of slides and 20 minutes for your questions. To submit a question, use the questions box located on the right-hand side of your screen. If you wanted, you could also type in that I'm coming in loud and clear. A copy of the slides can be downloaded under handouts on the right-hand side of your screen. At the end of the webinar, we ask that you take a short online survey. For every completed survey, WCRI will donate $2 to Kids Chance, which provides educational opportunities to children whose parents were either seriously injured or killed on the job. It's really a great organization. If you have audio issues, try listening to the webinar via phone. The number is listed in the confirmation email you received and on the right-hand side of your screen, again, under audio. If you continue to experience problems, rest assured that we will send you a recorded copy of the webinar along with the slides after the event. Here are your speakers today. We have Ms. Dong-Chung Wong, Dr. Randy Lee, and Dr. Catherine Mueller. Dong-Chung and Randy will do the presentation, and Catherine will be available during the Q&A to answer your questions. And so with that, I will pass on the baton to Randy. Randy?
Yeah, thank you, Andrew. Good afternoon, everyone. And I want to start with a set of two additional thank yous. First of all, to my distinguished colleague, Dr. Catherine Mueller from Colorado, whose work on this project was absolutely indispensable, and to the lead author of the study, Dong-Chung Wong, who in my opinion is one of the best workers' comp researchers anywhere. The second set of acknowledgments go out to our senior leaders, the WCRI board, Dr. Ruser and Ramona Tanabe, for allowing and enabling us to study those issues that are seen as problem areas in the world of workers' comp, or those about which there are still important yet unanswered questions. This time we studied, as Andrew stated, the timing of physical therapy for low back pain. Does it matter in workers' compensation? And you might say, you know, why this topic, but really why spine and why PT? Of course, most of you know the spine is still one of the most frequently injured anatomic areas encountered in workers' comp, but why PT? Well, it is a common first-line treatment. Most of you that are familiar with workers' comp injuries, you'll know that most individuals that get this type of injury, a number of them will have physical therapy as their part of their introductory treatment. But more importantly, it's also, or just as importantly, it's costly. The 2018-19 WCRI CompScope work found that across 18 states, the average physical medicine payment per claim varied from a low of about $2,000 per claim all the way up to more than $7,000 per claim, with the median being just north of $4,000. And the percentage of all medical payments for physical therapy services ranged from 10% to more than 25%. But there's wide variation, and part of that cost may be due to that wide variation seen in how it's prescribed, the types, the frequency, the duration, and intensity of treatment. But you know, the timing of PT is another a very important part of the PT regimen that needs consideration. Now, some may say, you know, or ask, isn't that already in the guidelines? And I would answer that question by saying, yes, we do have guides that include PT, but some of those guidelines may not be as specific and detailed about PT as they are other therapeutic services. So also, some of you may say, well, hey, look, hadn't this topic been studied before? And once again, the answer to that question is yes, but only in part. One of the better studies, one of the best studies that we saw in our review was that of Arnold's in 2019, which was a systematic review. He included 11 studies in his study that had to meet very stringent criteria, 6 of which compared early versus delayed PT. And most of those found that early PT decreased utilization and costs and also resulted in a better overall outcome. However, there were 2 major limitations to that study. The first limitation was that the definition for the descriptor early varied. Did it mean 2 weeks, 5 weeks, 6 weeks, a month? It varied. The second thing is that the mix of services differed from study to study. And then add to those limitations the fact that, at least to date, no one's conducted a comprehensive multi-state study on the topic in the context specifically of workers' compensation. So our study aim was to expand the body of knowledge in this topic by answering 3 sets of questions. The first set are these. What are the typical patterns in the timing of PT initiation for workers with low back only injuries? Second, how frequently are these patterns observed in practice? The second set of questions, when PT is prescribed, does early PT initiation help reduce the utilization of other medical services and improve the duration of disability? Conversely, does late PT result in higher utilization of medical resources and delayed return to work? And the final question that we had, a research question or objective, was what factors may have considerable influence on PT timing and outcomes. So Dong Chung will now describe our methods and results.
Thank you, Randy. Good afternoon, everyone. So let me go back. Okay. So I would like to start off with this part of the presentation by giving you a highlight of the some of the key findings from our study. So we're talking about low back only claims with more than 7 days of lost time. For this set of claims, we found that early physical therapy is associated with lower utilization and cost of medical services and shorter TD duration. Conversely, when we look at workers with late PT, after like 14 to 30 days, and we see increased utilization and cost of medical services and prolonged duration of temporary disability. In terms of specific timing of PT treatment, we found that workers who started PT after 14 days, especially after 30 days post-injury, the average utilization and cost of medical services increased, and we also see longer TD duration. There are several factors that are related to policy and practice that may contribute to late PT, and those are the factors that are also likely to contribute to the outcomes. So we're going to provide you a couple of examples in that area as well. So before we look at numbers, because this study is about PT treatment and the timing of PT treatment, so I would like to start, use a couple of, just 1 minute to talk about what we mean by PT treatment and how we measure the timing of PT treatment. So when we talk about PT treatment, we're talking about workers who had 3 or more visits for PT services. And by PT services, we mean, broadly speaking, we have physical modalities, we have manual therapies, and we have therapeutic exercise. Of course, we have like evaluation assessment. Those are the other categories. And for this study, we excluded workers who had only 1 or 2 PT visits. And those are the workers who are most likely to receive only evaluation assessment or some instructions for home exercise. So we do not observe, even if they have some exercise as a PT service, we do not observe them. So by looking at 3 or more PT visits, we're basically kind of looking at PT treatment that are provided in clinical setting, that are built so we can observe them in the data. I also wanted to mention that for this study, we excluded chiropractic care. So the physical therapy services that we're talking about today, those are mostly provided by physical therapists. And we measure the timing of TD initiation by looking at the number of days from the date of injury to the first PT visit. And we break it up into 5 buckets. So within the two-week time frame, we have 3 buckets of PT timing. The early PT within 3 days, 4 to 7 days, 8 to 14 days. And after 2 weeks, we have 15 to 30 days, and after 30 days. So we are looking at the, again, as mentioned before, the low back only claims that have more than 7 days of lost time. So we have about 26,000 of the low back claims. Those are mostly the simple spring strain and non-specific low back pains. And we have data from 27 states. A couple of exclusions that I want to briefly mention here is, for example, we excluded those low back claims that have the ICD-10 codes indicating red flag conditions, though they're example like a tumor, cancer, infectious disease, fractures, dislocations, and more severe, psychotic problems. And we also excluded low back claims that have nerve involvement. I'm not going to go into details of the rest of the exclusions, but the whole purpose of these exclusions that we applied is to basically create this set of claims that are clinically relatively homogeneous. So that helps us to mitigate some of the potential impact of the different severity across the different types of low back pain. And we're looking at the medical transactions data for the first year of treatment. So starting with the claim frequency over the PT continuum. So we're talking about here the percentage of claims that have PT visits, or of course, the extreme case would be no PT visits. So there are about 24% of those low back only claims with more than 7 days of lost time that did not have any PT services in our data. And about 7 to 8% of them, they had 1 or 2 PT visits. And a little over 20% had 3 to 6 PT visits, and close to half of them, they had 7 or more visits for PT services. So if you look at the 2 bars on the right, that gives us 68% of the low back only claims that have the PT treatment as we defined, which is 3 or more PT visits. So when we look at percentage of claims with PT treatment, this gives you a multi-state view. We have 27 states here, and you can see large variation. The lowest state is Louisiana, where we see about 45% of the claims had PT visits, meaning 3 or more PT treatment, 3 or more PT visits. And on the high side of the spectrum, we see Missouri and Delaware. In Delaware, we see 80% of the claims, they had PT treatment or 3 or more PT visits. So for those workers who had PT treatment, the question is, how often do they receive early versus late PT treatment? And so, as I mentioned before, we measure the timing of PT initiation by looking at the timing of the first PT, and we have buckets, which are listed here. The early PT within 3 days, 4 to 7 days, 8 to 14, 15 to 30, and after 30. So if you are looking at the two bars on the right, this gives you about 48% of the workers who had PT treatment, and the PT treatment started after 2 weeks post-injury. The same measure, when we look at that across the 27 states, the variation is substantial. But one thing I just want to mention here is that if you look at the two multi-state bar charts, and one thing that sort of jumps out is there are few states where fewer workers had PT treatment. And those are the same states where when workers had PT treatment, the PT treatment started later or more likely to start later. So those states, for example, like Louisiana, North Carolina, South Carolina, Virginia, those are the states on the higher side of this bar chart. So this basically raised two questions. Number one, does PT make a difference? And number two, does the timing of PT make difference? And our study does not address the first question. And for those of you who are interested in that topic and want to learn a couple of things, the Arnold 2019 systematic review paper that Randy mentioned about early on, that would be a good starting point. But our study does provide a number of lessons as to whether the early versus late timing of PT, whether that makes any difference based on the 20-state experience. So this just summarize the sort of a key point we want to talk about today. And so if you're looking at those low back only claims, the workers who had late PT after 30 days, and compare the outcome for those workers to the outcome for workers who had early PT within 3 days, the workers with late PT after 30 days, they were more likely to receive medical services. Specifically, they're on average 46% more likely to receive opioid prescriptions, and they're 47% more likely to receive MRI, and 29% more likely to receive pain management injections. For low back surgery, for this particular set of claims, the surgery rate is low, but when you trying to compare the early group and the late PT group, the workers in the late PT group after 30 days, they are 89% more likely to have low back surgery. In terms of our overall medical care, the late PT group on average, they have 24% higher medical cost, and TD duration is 48% longer for average workers in the late PT group within after 30 days when compared with the early PT within 3 days. So let's just use the TD duration as an example here. And again, we have 5 buckets that are the PT timing from early to late after 30 days. And the height of the bar here gives you the average number of weeks per claim for claims in each of the PT groups. And the percentages there below the number, and the up arrow basically tells you how much TD duration, how much longer the TD duration is for average worker in that group compared to the reference, which is the early PT group within 3 days. So for example, if you're looking at the bars on the right, far right, and so average worker with PT after 30 days, they have average 13 weeks of TD, temporary disability. And that is 58% longer than the average TD duration compared to workers in the early PT group within 3 days. And you may think of all kinds of reasons why we see the result we see here. So I just want to briefly mention that we controlled for various underlying factors, including workers and injury characteristics and state-specific factors, attorney involvement, and time to initial care. But I'm not going to get into details. So if you're interested, you could just go to the report or follow up with us through emails on those technical issues. But I do want to emphasize that because we controlled for a rich set of underlying factors, we see evidence of a strong association between the early PT initiation and lower utilization and cost of medical services and shorter TD duration. But the association is not causation. And the reason I say that is because we were unable, even though we tried several ways, but we were convinced that we could not control for the certain unobserved characteristics of injured workers that might affect PT timing and outcomes. So again, I just want to emphasize that we are not measuring causal effect of the early PT. So we have talked about the relationship between the timing of PT and outcomes we studied, and then the question really is how early is early, or more so, how late is too late. So this study, we do not address optimal timing for PT initiation, but we do look at the patterns in the results of the outcome variables we studied, and we see evidence basically that made us to conclude that the 14 days is pretty good marker for late PT. And I'll illustrate using the next slide. So again, remember we have 5 buckets for PT timing, and you can see here is 4 to 7 days, 8 to 14, 15 to 30, and after 30 days. We're missing out that early PT group within 3 days. That's the group that we're using for reference. And so this chart basically shows you the percentage differentials. And the height of the bars actually shows you the value that is above or below the values for that early PT group within 3 days. And we have 6 outcome variables or utilization and outcome variables here. So specifically, they are the percentage of claims with MRIs and percentage of claims with opioid prescriptions, percentage of claims with injections, surgery, and average medical cost per claim, and average number of weeks of temporary disability per claim. So the asterisks here that basically shows that percentage differential actually is statistically significant at 1% level. So basically that says that if we're doing several other, doing studies with somewhat different samples, we're going to still find the same thing. And so when we are trying to draw a vertical line here to separate out the 2 weeks, and before the early PT within 14 and PT after 14, basically just a step back, and you can see this chart, and you can see for yourself that the workers with PT after 14 days, that on average they have the higher utilization of medical services and have a higher overall medical cost and longer TD duration, especially for that group with PT after 30 days. So getting to the last section here, there are several factors that are related to policies and practice that are likely to contribute to the late PT treatment, but they're also likely to affect the outcomes. And we just give you 2 examples, and you can see more in our report. So this chart basically shows you the percentage of claims with attorney involvement, and we use attorney involvement sort of as a proxy to indicate the extent of the pending compensability issue. We know that it's not perfect, but this is one of the ways as an indicator. So you can see that across the 5 PT timing groups, the late PT after 30 days, we have 27% of the claims that had attorney involvement, which is much higher than the workers in other PT timing groups. And when we look at the number of days from injury, date of injury to the first medical services, this is the first initial care. This is not the first PT. This is the first medical care. So again, the 5 PT timing categories and late PT after 30 days, we have the highest number of days, the longest wait from injury to the initial medical care. So basically, there are a couple of this measure may reflect a couple of underlying factors, including the pending compensability and including how fast or how prompt the notification were made, and including whether there are any certain access issue to care, and also including injured workers' care-seeking behavior. So this is just indicator of those potential factors that might sort of affect or have an effect of delaying care. So with this, I just have this major funding recap, but I'm not going to spend any time reading through the slides, and you can probably just read that and make your own conclusions. But I'll give this back to Randy.
Yeah, thank you, Dong Chung. And just to reiterate, our evidence can't be labeled as cause and effect, but there was a statistically consistent and strong association that's not only scientifically coherent, it makes common sense. So our 14-day threshold may not be the final word on the subject, but it is a great start in the direction of answering the timing question around PT. Specifically, and I guess if you were going to try and talk to a cognitively challenged orthopedist, we don't read our emails thoroughly, and sometimes we don't get the details, but if you wanted to get the bottom line, what you would say is if PT is going to be ordered, early is better. And knowing that prompts the question, what impact could that have? Specifically, what impact could that have on the various stakeholders involved in comp? Well, providers, what about providers? Well, we know that some wait for as much as 3 to 6 weeks or more before ordering PT. And our findings that suggest for better outcomes, they may want to start ordering PT a bit earlier. Then employers, providing early access and intervention to decrease costs and utilization. That's been a prominent theme in discussions around work-related injuries and illnesses for better than 20 years. Our findings align with that concept. That is, early PT intervention is beneficial from a cost and a clinical standpoint. And let's consider payers. As payers manage cases, they schedule set-asides and reserves using predictive analytics, and it just may be that the initiation of PT in less than 14 days will end up being a marker for a good outcome. And if initiated after 14 days, maybe not so good of an outcome. And let's don't forget patients. For a variety of reasons, patients at times might avoid or even refuse care. Let's say for whatever reason they don't trust the care being offered. Here, I think making a concerted effort to include shared decision making in the care plan is important, specifically to let them know that research is suggesting outcomes are less favorable with delayed care. Now, of course, regulators are key stakeholders in this as well, and they may want to strongly consider policies that encourage early PT. Now, I want to pause for just a moment and backtrack a bit. Early in this discussion, we mentioned treatment guides and the fact that they aren't quite as specific and detailed in some respects, such as timing about PT. Perhaps the results of research of the type that Dongcheng just presented and that we conducted could enhance that detail and specificity of guidelines. Now, the final implication that I'll mention has to do with further research. So yes, this project did improve our ability of being able to answer the PT timing question, but there's still a lot of other questions to answer regarding PT care and the PT sciences. For example, our study only included patients receiving physical therapy services. Think about this for a moment. How would our early PT patient outcomes compare with a cohort of patients not receiving any physical therapy? Here's another area that we want to pursue. Specifically, we want to look at the data to identify and examine the PT patterns of care and then determine their impact on utilization, cost, and TD duration. Look for that. That may be coming out. That's a spoiler alert. It may be coming out in the near future. And here's a final potential research question. How do the outcomes of physical medicine services vary based on the type of provider providing the services, say physical therapy versus chiropractor or whoever else is doing it? So stay tuned. We should have some subsequent reports on the topic within the next, few months. So Andrew, I'll turn the program back over to you so we can take any questions you may have. Thank you.
Great, thanks, Randy. So I'm just going to advance to our last slide. So before we go into Q&A, we just obviously want to say thank you. We know some of you may have to take off early. We want to obviously thank our members who are on today's call again. Without your support, we wouldn't be able to provide this research and these webinars. Non-members can learn more about the benefits of membership at the address on the screen. Save the date. WCRI's 37th Annual Issues and Research Conference is going virtual March 23rd and 24th, 2021. We have expect an email right after the new year about all the exciting details and the agenda that we have planned for you that I think you'll find both valuable and very interesting. And if you're not following us on social media, we hope you will. It's a great way for us to stay connected with you, to share our latest research, and also inform you about upcoming events. And with that said, we're going to move on to our questions. If you look on the right-hand side of your bar, you will see a questions feature. Again, open that up, type your question in, and click send, and we'll answer as many questions as we can within the time allotted. Before we do jump into those questions, I would like to ask a question to Dr. Mueller. Dr. Mueller is one of the longest tenured medical directors in the country working for a workers' compensation agency. How do you see these types of studies being useful for state regulators?
Thank you. Well, I think there's quite a bit of interesting information. And in addition to what you've already heard, there are some places in the article where you can look for state-specific information I'll go over. And I'd just like to start out with, as already mentioned by Dr. Lee and Dongcheng Wang, that the prior studies really did not get into the details of things that affect workers' compensation patients, besides looking at the workers' compensation system. So I did want to mention a few of the sensitivity things that we looked at. In other words, there's a number of models that Dongcheng actually was wonderful at developing, where we adjusted for different factors. And these are factors that are really important in workers' comp cases and that you didn't see looked at in any of the prior studies. So in addition to the normal things that you see in the WCRI studies, demographics, age, gender, weekly wage, tenure with employee, etc., which are things you don't find in other studies, firm size, and state-specific factors, which is really important because as a state regulator, you want to know that the things you're looking at have been balanced to some extent for policy changes between the states. But what really mattered, I think, is that we have these additional areas, and the way we looked at some of the comorbidities and things that you could only really look at in a certain way in workers' compensation. So some of the studies had looked at comorbidities, which if you look at our study, you'll find that comorbidities are a very important predicting factor. And some of them looked at it purely from medical diagnostic point of view or the year prior to the injury. Now, obviously in workers' comp, we don't have the year prior to the injury. So we used similar comorbidities that were found in the charts. We did have concerns whether they would actually be enough of those in workers' comp charts to make this reasonable. But I feel fairly confident because, in fact, we found that they did predict, just as they did in the other studies, that actually that was a reasonable way to look at it. But in addition to that, we also looked at was there chronic pain mentioned early on in the diagnostic categories, and we used that as a substitute for what might have gone on prior to that injury to see if there were actually pre-existing sorts of things. So I think those are big strengths in the study. We looked at and again, as you go through the study in detail, you can see these things. Also looked at whether or not the PT was essentially internal. Now, the only way we could do that was to look at the tax IDs, but we know that PT would probably be given earlier in a situation where PT was part of the initial provider system, and perhaps later if not. And so those are interesting things to consider when we're going to get to the bottom line. I'm going to talk in a minute about what things in your state you would want to think about to try and improve care. And then we also had this external county level data, which is pretty fascinating because it included not just the providers that are available, but urban and rural settings and physical activity in counties, and all of those are very important. Only some of those were looked at in other studies. So I did want to make that point, and you can see the various models when you go into the study. So that helps you also, I think, as a state regulator, because you know how many urban centers you have, how many rural centers you have, and sort of how does that work. But let's look at some of the tables that are in the supplemental area that I think have the interesting information. So if you look at table SA, and if you go to the supplemental part, what you would find is the timing of PT initiation post-injury. And Darton showed one of those charts, but this gives you the actual percentages. So I thought you would find it interesting to know that of states that had 60% or more of all of their PT cases occur after 30 days. So 60% of all their PT cases were started after 30 days. There's 5 states like that. If I was one of those states, I think I'd want to look at that because it seems like the prediction there is not very good. And then if you look at the 15 to 30 more, so 15 or more days. If you look at states that are 15 or more days, 13 of those had more than 50% of their PT cases in there. So from a state regulatory point of view, if it's me, I'm going to look at that and say, where am I? And if I got that many late cases, I need to start thinking about, is there something in my system that somehow is contributing to this? So is there too much prior authorization? Are they not seeing a provider soon enough after the injury? Are there some other kind of regulatory things? Or in many states like we do, you could teach providers, educate providers. So it really gives you a little snapshot into your own state that you can start to say, what sorts of things might be contributing to this when I know it's going to cause higher cost claims. And there was one other thing I noticed that I think people probably would want to look into, and that is just in general. I know we were using opioids and MRIs as outcomes and surgery as outcomes, but if you look at, again, some of the supplemental charts, for patients that had 3 to 6 PT visits, so I'm only looking at those because more than 7, those people maybe have more complaints, have more issues, maybe they would be more likely to have an MRI, right? But these are people who only have 3 to 6 PT visits. About a third of those patients got opioids, and about a third of those patients got MRIs. That doesn't comport well with what most guidelines would say should happen to patients who just have low back pain, have none of the red flag factors, and then they're not getting that much physical therapy, so we assume they're not that acute. So those are all things that I think as a regulator, when you're trying to improve your system and improve the quality of care in your state, that you can glance at. And I know we will continue to provide state information like that, even if it's not run statistically to tell you whether you're statistically worse. You can look at it yourself and see whether it's a predictive value for what's going on in your state. So I think there's other information in there besides just the main findings that we have that can be useful to people in looking at their state systems.
That's great insight, Dr. Mueller. And for those, for our members, this study is free for our members and available on our website. And we'll make sure that we send you a link after the webinar, along with a copy of the recording of this webinar. For non-members, it's available for purchase, but free if you become a member. So another plug for that. We see a lot of questions coming in, so I'm going to jump right into those. First one comes from Savvy. Is it possible those with more severe injuries would need to wait longer before initiating PT?
Maybe I'll start with this. This is actually the very issue that we concerned about from very early on, and that motivated us with trying to figure out how much influence could that be, that workers with more severe, relatively more severe claims, more severe conditions that would take some time, and then before getting on PT. Number one, I think the one reason that we do not think it has a really material impact is because we are looking at low back only claims, and those are the claims that have just the spring strain, low back pain, non-specific low back pain, and we excluded the claims with red flag conditions. We excluded claims with neural findings and even like shooting leg pains, those things that are mentioned in the data. And so we are dealing with relatively less severe low back pain and clinically more homogeneous to start with. And then we also controlled for several factors, including we identified comorbidities. Those are including obesity, like alcohol or drug abuse, diabetes, smoking, and so on and so forth. The limitation is that probably workers' comp data kind of under identifies the comorbidities because that's not the conditions workers' comp is treating. But we do see that comorbidity has, varies and goes in the direction that we suspected. So after the controlling the comorbidities, it really controls for some of the severities there, and conditions that need to be dealt with before PT initiation. And another thing we controlled is we have pre-PT injections and pre-PT surgeries, and those are invasive invasive procedures. So it's not like really can be affected by practice patterns. So we use those to also as an indicator for severity. And we also have several others, and including case mix adjustment. So basically we try to control the underlying factors that could result in that some more severe cases get late PT. After that adjustment, certainly the magnitude of the effect of early PT got reduced considerably, but the effect is still there and it's significant.
Anybody else want to answer that? Or next question?
I had just one comment that I would add to that. I think, one of the things we've been talking about and we've more or less discovered that's becoming it's an emerging topic in the literature, is making a distinction between severity and complexity of patients, because complexity is the issue that involves not only comorbidities, but it also includes utilization, and it includes the social determinants of health. So you know, when you get a clinically homogeneous group, the complexity then seems to play probably a bigger role than the variables used to control for severity at some point. So the short answer is I think there's a lot of work to be done on that, and it's interesting. But I just wanted to mention that because I think you're going to see more mention of that term, the term complexity. And it's not part of the complexity science theory or any of that. It's something completely different, but it is of interest.
All right, our next.
That's a great add-on, and basically in the second study we're trying to look into that area and you know, the patient complexity, and trying to establish a set of markers so that we can tell, or we can control, not only medical severity but you know, patient complexity.
All right, the next question comes from Robert. What do you anticipate as challenges in attempting to answer the question of PT versus no PT?
I would say severity or complexity.
All right, next question comes from John. The study, consistent with most all WCRI studies, only includes cases with more than 7 days of lost time. Any plans in the future to change your study populations?
The short answer is yes. We are considering including in our subsequent PT study, we're considering including the claims, not only low back only claims, but also claims with nerve involvement. And we're including, at least we're trying to include all claims, regardless whether they have more than 7 day lost time or less or equal to 7 day lost time. But the purpose of doing this study, because we were dealing with this the confounding, if you will, the confounding issue. And this first study really serves as a kind of a feasibility and see how far we can go in that direction. So we just try to, you know, start off with a relatively simpler set of cases and claims with more than 7 day lost time that basically helps in terms of comparability when we talk about outcomes across different timing groups. But the subsequent study is designed to include, you know, more claims and claims with no lost time.
Next question comes from Anthony. The 80% surgery rate when PT is initiated after 30 days appears high. Are you confident or have additional information to offer?
I should clarify. I think it's probably that on the slides it didn't clearly marked, but the 89% there it tells you how likely that workers with late PT would have surgery relative to workers who had PT early within 3 days. So it's basically, if you were to compare workers with late PT after 30 days with those who had early PT within 3 days, the late PT group, they are like 89% more likely to have surgery. Though the surgery rate is very low, it's in the single digit for this set of cases.
Our next question comes from Les. I can't help wondering if, from a biopsychosocial perspective, if those who got earlier care felt less contested and more heard, and so had better outcomes. Still wouldn't demonstrate any causality, but there seems to me to be a lot of candidates for a third variable leading to earlier care, only some of which are medical in nature. Thoughts or speculations about this, about any of that?
I think that's definitely an important issue. And because we didn't look at also those who only had 2 visits, you know, the speculation about having early visits and a few visits would be that sort of support. So we may be able to look at those 2 groups in the future to see whether that kind of pans out, because that also would be a way of supporting a person. So we don't know how much of that is in there, but I definitely, I think everyone would argue that that's an important issue, is validating the person's complaints early.
Our next question comes from Sarah. Within the adjusted factors, was referral source included? Was there any difference between primary care referral versus orthopedist referral? Were there any patients who saw a physical therapist first without a referral?
That's a very good question. And unfortunately, we do not have adequate information in our data to separate out the type of providers and specialty and to link that to the PT referral. But it's a very good question. Some of the studies address that. And we this is one of the things in our consideration initially, but we just do not have the good data on that.
We have a question from Joe, I think speaks to some of the earlier slides. Was there a limit on the TD duration? Was it limited to the lost work in the first year post-injury?
The way we look at data is basically to look at the first year of treatment starting from the date of injury. So the TD duration there is basically derived, evaluated, 365 days after the injury. I hope this answered the question.
Our next question comes from Saeed. Why does having attorney involvement result in such a long delay in initial care? And do patients with similar backgrounds, e.g. demographic, tend to have attorney involvement?
This is a workers' comp population. So one of the key issue is like when somebody got injured, the very first thing would be whether this is work comp related. So especially, if you have objective injury, you got, injured on the work, and that kind of a clearly establish a link between injury and workplace, that's great. But for low back, because of the nature of low back, it's and subjectivity of the low back pain. So it could be more so in terms of compensability dispute, and whenever you have a dispute, you would have attorney involved. But having that said, the attorney involvement, it could be indicator for pending compensability, but it could also be indicator for a lot of other issues, including, later on in the claim, the impairment reading and the compensability issue, the disability rating issues, and it could also be that if there's a dispute in terms of certain medical services that providers prescribe, but that didn't get through utilization review, that could also prompt a certain dispute. So the attorney involvement we used here is only as a proxy, as an indicator. It's not really just for compensability. It's just one thing we can use to sort of shed some light on the issue.
And Saeed, one of the things as a clinician that I used to see, and this is not really a research-based statement that I'm going to make, but it's more experiential, is that if I would see a patient that was seen by another provider, and they did say they didn't recommend physical therapy, they went to one physical therapy provider. Once they got to the attorney sometimes direct care still, and so that would, one of the delays was they would get referred to physical therapy, or they would wait to get their care until their attorney made that recommendation. So that could conceivably have something to do with it from a practical standpoint. That's what I've seen. And Catherine, that may have been the experience that some of the things that you've adjudicated or reviewed in your state that could conceivably happen as well, I would think.
I think we happen to see more of the causation disputes, the not accepted claim up front with the problem.
Great. Next question comes from Morgan. Were there different levels of MRI or injection utilization in cases when the PT was offered with the system, within the system versus outside?
When you say outside, is outside workers' comp?
That's what it sounds like. Were there
I,
different
I
levels of
think
MRI?
no, I,
Sorry.
I think what they're talking about is maybe within the same system. For
Yeah.
instance, if they're in a big health system, was the utilization higher within a health system? Because it was in a health system, they went ahead and so-called, just hey, we're going to go ahead and run them through this mill. Not that it's a mill, but you know what I'm saying. They tried to get them to, they directed care more within the system. Whereas if they were a private practitioner A, they might have sent them to somebody else B, totally unrelated to them.
I don't know if we looked at that.
Our next question comes from Zachar. Did the study have any way of taking into consideration late reported claims by either the employer or injured worker?
That's a very good question. Actually, I think if the injury got reported late, that would manifest it into the measure that we have from the date of injury to first medical care. But we do not have the ability to disentangle it. And we do have, we were trying to capture the date of notification to the employers, notification to the carriers, but those fields are not systematically populated when the data gets to us, so we're not able to tell whether that's the case or not.
Andrew, I don't think we completely answered Morgan's question from the previous one. I think the point she was trying to get to is do self-referred or say you own the physical therapy center or you own the MRI unit, the provider does. Is there a higher rate of referral, and how does that impact the results of our study? And we have that data, but I'm not sure. Dongchun, can you comment on
Yeah,
it?
I was thinking about that too, Randy, when we were there, because for example, we have, as Catherine mentioned, that we established the so-called same billing provider or same billing healthcare organization, which is basically that the same tax ID that we see for providers who provide initial medical visits and who also provided the PT service. So that's what we call the same billing tax ID, which could be in-house PT under the same roof, or could also be affiliated with a financial organization that are, the tax ID are used for billing, because we're dealing with we're using billing data. And so there are two competing hypothesis for this, because initially when we look at data, our hypothesis, Kathleen initially mentioned that what if at organization level they have a protocol that sort of emphasized on early PT and also trying to have certain things in place to improve care, to control cost. And if that's sort of linked, then if that's true, then the cases with early PT may have better outcome, not because of early PT, but because of the organization level protocols. And we do see that among early PT cases, much higher percentage of the claims that have the same tax ID, same billing tax ID. So, but when we take the same billing tax ID and throw that into regression to adjust for it, we didn't really see clear evidence that would sort of compromise the comparisons in the utilization, medical costs, and outcome. The other side of the competing argument could be that Randy mentioned, what if there is a presence of self-interest? The same tax ID, they self-referral patients to their own organization, and those are, I don't know, the organizations, they are more likely to provide MRI, because there's certainly studies in the literature that talk about self-interest on the increased use of MRI and surgery. And it could also be, this would be the competing argument. In our statistical analysis, we see some effect of tax ID, but we do not have a way to disentangle, which force of it is that sort of underlying the same tax ID. We only observe the same billing ID. If that's adds some insight here.
Well, unfortunately, we reached 1 hour. It's a great conversation today. I want to thank, number one, our authors and speakers for today for a great report and a great presentation. So thank you, and thank you to you who attended today's webinar. We're so glad you joined us. We hope to see you next year on a future webinar. And in the meantime, from everyone at WCRI, we want to wish you happy holidays and a safe and prosperous new year. Thank you for joining us today. Have a great day.
Thank you. Bye.